morning and a very warm welcome to everybody to the ASEAN Pandemic Readiness webinar series. This series is jointly organized by the ASEAN Diagnostic Initiative, the Program for Research in Epidemic Preparedness and Response, and the Asia Partnership for Emerging Infectious Disease Research. My name is Yuan Lu Ho, and I am the co-lead of the ASEAN Diagnostic Initiative. I'll be your host today. To kick off this webinar series, I would like to share a recorded message from Prof. Jaime Montoya, who sends his apologies for not being able to join us in person today. Prof. Montoya is the Executive Director of the Philippines Council for Health Research and Development, and also the founding co-lead of the ASEAN Diagnostics Initiative. So, Prof. Montoya, please.
To our chair and moderator, Professor Leo Yee Sin of the National Center of Infectious Diseases, Ministry of Health in Singapore. To our speakers and panelists, Dr. Judith Bong, Dr. Chia Po Ying, Professor Dr. Ernie Juata Nelwan, Dr. Ronjin Solante, Associate Professor Nasikam Angkasikwinay, and Professor Lisa Nang. I would like to take this opportunity to thank each and every one of you for dedicating your time in sharing your insights and expertise to the participants of our webinar series. I would also like to thank our participants today for joining us in the endeavor, and especially to my fellow organizers for the webinar, the Asia Partnership for Emerging Infectious Disease Research, the Program for Research in Epidemic Preparedness and Response, and our ASEAN Diagnostic Initiative co-leads, DXD Hub from Singapore, and the PCHRD. The objective of the ASEAN webinar series is to facilitate knowledge exchange, collaboration, and strategic discussions among experts, researchers, and stakeholders in the field of diagnostics, with a focus on addressing emerging health threats within the ASEAN region and foster cooperation and preparedness against emerging diseases within the ASEAN community. This is aligned with the United Nations Sustainable Development Goals to ensure good global health and well-being. ASEAN, with its strategic geographic location, diverse ecosystems, and high population density, create an environment conducive to the emergence and transmission of infectious diseases. These infectious diseases recognize no borders, which further amplifies the importance of a swift, unified response in and amongst Asian nations against emerging diseases to mitigate their impact on public health and to safeguard the well-being of communities across Southeast Asia and beyond. Today, we will delve into the intricate challenges posed by arboviruses and exploring potential strategies to fortify the ASEAN region against the incoming threat. The expertise that will be shared by our esteemed speakers is invaluable, shedding light on the importance of collaboration, early detection, and a unified approach in our journey towards resilience. It is evident that the path ahead requires a collective effort, with ASEAN neighbors standing shoulder to shoulder, sharing knowledge, and bolstering each other's capacities. The commitment, and that will be demonstrated here today, underscores the strength of our regional solidarity in confronting public health challenges. As we start with this new ASEAN Pandemic Readiness webinar series, let us remember the importance of collaboration, information sharing, and swift action in the face of emerging health threats. Together, we can build a resilient and prepared ASEAN region to safeguard the health and well-being of our communities. And I hope that after this virtual event, We will remain proactive in implementing the recommendations discussed today and foster a culture of preparedness within our respective nations. On behalf of the organizing team, I extend my heartfelt congratulations and appreciation to our panelists and to every participant for supporting our endeavor against arboviruses. Together, we can build a resilient ASEAN community. Thank you very much and good morning to everyone.
Thank you, Prof. Montoya, for the reminder of the importance of regional collaboration. And on that, I would like to introduce our moderator for today, Prof. Liu Yi-Sin. Prof. Liu served as the Executive Director of the National Center of Infectious Diseases in Singapore from 2017 to 2023. During her tenure, she established many practices and established NCID as an innovative organization integrating clinical care, public health, research and training, and community outreach. She has led teams through multiple outbreaks in Singapore and is a recognized authority in the field of infectious diseases and outbreak disease management in the ASEAN region. She also serves as a member in numerous committees and advisory boards, including multiple WHO work groups. Prof. Liu has since stepped down as the ED, but now continue to contribute her expertise as the senior advisors to NCID and MOH in Singapore. It is our privilege today to have her here to guide the discussions on the challenges, prevention strategies, and advancement in technologies in arbovirus management in our region. May I invite Prof. Liu, please?
Thank you very much, Jinu, for the, I must say, very, very generous introductions. So welcome to today's first of the series of ASEAN Pandemic Preparedness webinar. And today's topic is on arbovirus. And this is a topic that is very, very relevant to these regions, affecting all the ASEAN countries. And today, we put together 6 of our speakers that are internationally well-known, esteemed, and experts in this particular field. And I'm very sure they will bring to you their very well-informed knowledge to be able to share with all our participants in today's webinar. Let's come back to the objectives, why this webinar is being put together. So we hope that through this platform, we can exchange best practices on emerging infections and also help us to be better prepared for the potential next pandemic. And in today's sense, we all know that we have to get ourselves ready after learning from the COVID pandemic. And I think more importantly is to bring together the friendship and also the network to be able to explore many more ideas that's going to come and better collaborations in this region. And we are hoping to expand the ASEAN diagnostic and many of the partners here today to be able to share with you their network and also their experience. Let me just quickly acknowledge many of the multi-partners that have been put together to make sure that these events can be put together in a meaningful way. So these multiple partners include the ASEAN Diagnostic Initiative. You have heard the ASEAN DXD, the Diagnostic Development Hub, DXD Hub, and the Philippines Council for Health Research and Development, in short, PCHRD. PREPARE is national programs by the Ministry of Singapore. Essentially, is to strengthen Singapore's capabilities to respond and to be able to research should we encounter another pandemic. And also the Asia Partnership on Emerging Infectious Disease and Research. In short, we call it APEIR. And I'd like to thank and acknowledge all the multiple partners putting in their effort, providing their resources as well as expertise to make this webinar a useful one to all our audience. Please feel free to put in your questions in the Q&A box with you, and we will then address it at the later part of the program today. So let me first start off with our speakers. We have altogether 6 speakers, and my introductions of the speakers will be relatively brief because each one of them will be only given 10 minutes to give their presentations. But they are informations where you can get of the speakers, and please feel free to get acquaintance with them and continue the discussions and sharing of the experience with each other. And what I will do is to introduce each speakers, and then I will allow all the 6 speakers to complete all their presentations, and hopefully we will leave behind enough time for the Q&A discussions. So let me quickly call up our first speakers, Dr. Judith Wong. Judith is currently the director at the Environmental Health Institutes in the National Environment Agency in Singapore. So she will give us an overview on the evolving epidemiology of the arboviruses with the very specific topics on dengue. Without much ado, let me just call upon Dr. Judith Wong to give her presentations. Judith.
Thanks, Prof. Liu. Give me a while. Okay. Right. Okay, thank you very much, Prof. Liu, and good morning, everyone. Thank you for the introduction, and I would like to also thank the organizers for the invitation to present. So I will go very quickly now into what I will be presenting. So really, I will touch a bit about the arbovirus circulation in the region, very briefly, and then I know the rest of our speakers will take it further, and also describe a little more about the challenges and advances that we face in the region and also in Singapore in tackling arboviruses. So I'll first provide an update on the circulation of dengue and chikungunya in the region, and also touch briefly on Zika. So we know that Southeast Asian countries are known to be hyper-endemic for dengue. And in this chart here, we can see the plot of the force of infection globally. So the force of infection is broadly the rate at which a susceptible individual may acquire an infection at any point in time. And we can see that most of the countries here, as you see the ones on the right, they would really largely come from Asia. So most countries in Asia had a higher force of infection for dengue compared even to countries in the Americas. So this is also particularly pronounced for countries like, for example, Vietnam and Thailand. So with this as a start, allow me now to provide a more recent update on dengue cases in our region. So in the past year, we have seen continued rising cases in most countries, with outbreaks in hundreds of thousands. And this is particularly pronounced for Bangladesh as well as Thailand. So in Bangladesh, it was a 4 times rise last year compared to 2022, and there were 5 times increase in the number of deaths. For Chikugunya, we also continued to see cases in the region, with India reporting about 93,000 cases. And although we don't have the figure for Zika, we also know that last year there had been Zika cases in Thailand, Cambodia, and India. And even in Singapore, we had about 20 over cases in 2023. And this is a considerable number compared to 2022, when we only had 2 cases. So taken together, our region does show that we do see continued arbovirus circulation. And really with the increased global travel and connectedness, our countries will continue to face the risk of virus exchange and inflows. So with that, I'll now move on to share more about Singapore's dengue situation and the challenges and advances that we've had encountered. So this graph here shows the historical case trends of dengue since 2004. So that's about 2 decades of dengue cases. And the black line indicates the number of dengue cases, while the colored areas show the proportion of different dengue serotypes. So Singapore has had experienced cyclical outbreaks in the past 2 decades, with large and significant outbreaks in recent years. So this was caused by dengue 2 in 2019 to 2020, and also dengue 3 serotypes in 2022. Now, despite the increase in number of dengue cases and the outbreaks that we have observed, so this can be seen in the red line, we have, however, observed a paradoxical trend between dengue cases and the force of infection. So the force of infection can be seen in the green line, which we know it has gone down steadily, really over the past 50 years. So the decline in the dengue force of infection could possibly be attributed to Singapore's good vector control program. So it has been implemented for many decades now. And this is also evidence as seen in the Aedes House Index in the blue line in the graph below. So then why are cases increasing? So one possible explanation that we have could possibly be the increased case ascertainment in dengue. And I'll share now a bit more about our experience with case diagnosis and surveillance for dengue. The National Environment Agency, which is the agency that I'm from, and the Ministry of Health, which we work very closely with, we have established a comprehensive dengue surveillance program, as seen in the schematic on the left. So in addition to testing hospitalized cases for dengue, the diagnostic labs in our agency also test samples from a network of primary healthcare practitioners, which then provides early diagnosis and enhances case surveillance for dengue. So the case and cluster information from across the country is then fed back to our vector control teams for timely vector control and response. Further, in our laboratory, we have also tested the dengue negative samples for flaviviruses, meaning other flaviviruses, and chikungunya as a way to enhance surveillance. So while the schematic on the left describes our surveillance workflow, the schematic on the right, or rather the map on the right, shows the coverage of primary healthcare practitioners that we have under our surveillance framework. So this surveillance system has been set up since 2006 and has been enhanced over the years. So community awareness about dengue, improvements in case detections, could therefore partially explain the paradoxical trend that we have seen and the increased number of cases reported. So our agency also conducts regular sero-surveys of dengue to understand the population immunity. So indeed, with the good case surveillance and vector control, our population immunity has steadily declined across all age groups over the years. So this can be seen on the graph on the left. Hence, one other possible explanation for the increased number of cases could be due to the overall low population immunity in Singapore, which then puts us at risk of large outbreaks, as we have seen in recent years. So this therefore highlights the unique situation that we are in, that we have declining seroprevalence rates, population immunity, we are at risk of dengue, and we already have implemented vector control. So what this means is that we really do need a paradigm shift in tackling the mounting challenge of dengue and in pushing the frontiers of vector control further to manage dengue. So while we have had successes in vector control, we have really employed also new technologies to further control the mosquito population. So this is through Project Wolbachia, which those who are in Singapore might be aware of. And we have employed Wolbachia technology using the suppression approach to control the mosquito population or the Aedes population in Singapore. So Wolbachia-carrying male Aedes aegypti mosquitoes will be released into the field, and the Wolbachia-carrying mosquitoes will actually mate with wild-type females, and as their eggs were not hatched due to cytoplasmic incompatibility, we would then in turn control the vector population. So I'll share a bit more about the results that we have from Project Wolbachia now. So this map here visually shows the impact of Project Wolbachia for 2 towns which has had Wolbachia releases since 2018. So we have deployed mosquito traps across the country. For those of us who are in Singapore, we might have seen that. And that's really to monitor the vector control, to monitor the vector population so that we know where to target for vector control. So these traps have come in very useful when we had Wolbachia releases, because it then helped us to estimate the entomological effect of Project Wolbachia. So the areas in red would actually show the mosquito population. So we could see that those that are intensely red would have more mosquitoes, and those who are the areas in pink would have less mosquitoes. And of course, those in gray do not have any detect. So as we increase the coverage of Project Wolbachia as indicated in the blue lines, we would actually see like an eraser effect in the mosquito population. And in this graph, we also further show the data in terms of mosquito population as indicated by the red line. And this has declined as we increase Wolbachia coverage as indicated in the green dots. So there is a very good correlation in the sense that when Aedes aegypti abundance declines, then there is an increase, it declines with increased Wolbachia coverage of the town. And these are 4 towns which have had Wolbachia releases for quite a number of years now. So we next asked, like, in addition to controlling the mosquito population, because the other concern then is about dengue. So we asked if Wolbachia coverage could reduce dengue transmission. And this map here shows a visual representation of areas with Wolbachia coverage as indicated by the black boundaries, and how visibly there are fewer dengue cases as indicated by the blue circles compared with the other areas in Singapore. Hence, in addition to reducing the mosquito population, we have seen that Wolbachia technology has helped to reduce dengue transmission. So in our agency, we have plans to progressively increase our Wolbachia coverage. So earlier on, these were really initially as trials, and then we progressively expanded the coverage. And we have plans to cover up to 35% of our households by this quarter. So with that, I would like to end with this slide. So taken together, we do really need to tackle like 3 different things when we think about dengue control. So vector control is key. And of course, the population immunity and population susceptibility is important. And also, we do need to understand the virus and whether or not there are more transmissible ones like circulating. So while we know that really in terms of like in the field, we do know that dengue or other arbovirus circulation continues to put us at risk, we also know that there has been increasing like developments in the area of technology for example, for surveillance and for tools in understanding the virus. In terms of vector control, there is also Wolbachia technology, in addition to many other tools. And more recently, also, there are the development of vaccines, as well as antivirals that could help us collectively bring down or control dengue. So really, while it is worrying that there is continued risk of arbovirus transmission, we do see hope in the sense that there are novel technologies that are being progressively made available. So our responsibility as a public health community would then be to evaluate the effectiveness of these tools in our local epidemiological context, especially since it could vary quite a bit from country to country. So with that, I would like to end my presentation. I would like to thank the organizers for the chance to present, as well as Associate Professor Ng Lee Ching, our Group Director, for guidance. And the work comprises efforts from the Microbiology and Molecular Epidemiology Division, who has conducted the work on dengue case surveillance and sero surveys, as well as the Vector Biology and Control Division, which has led the Wolbachia efforts, and the Environmental Epidemiology and Toxicology Division, who has supported with data analyses. So with that, thank you.
Thank you very much, Judith. Thank you for bringing us up to date on the situations of the arboviruses in Singapore, and also some of the new approaches and new technology. I think now we should move on to our second speaker, Professor Chia Po Ying. Dr. Chia is currently the consultant and infectious disease clinicians at the National Center for Infectious Diseases and the Department of Infectious Disease in Tan Tock Seng Hospital. She will share with us the diagnostic and therapeutic challenges in clinical management of arboviruses in Singapore. Po Ying, please go ahead.
Thank you for the kind introduction, and I would like to thank the organizers for having me here as well to give a short talk on the diagnostic and therapeutic challenges in dengue in Singapore. And without much further ado, so in terms of disclosure, I'm just running a sponsored trial by Novartis. Otherwise, there's no other disclosures. And as clearly shown before by Dr. Judith, actually, so this is a chart of the dengue situation in Singapore in terms of the premise index as well as the dengue cases. So in spite of the very well-controlled vector program that we have, we do still have increasing subsequent increase in dengue cases. And similarly, for vector-borne disease outbreak, it actually hinges on 3 factors. So the vector itself, the host and the host immunity, as well as the virus itself. And as we can learn from COVID-19, when there's a change in the infectivity of the virus, it can also result in outbreaks. So Singapore's situation is that we do actually see that there has been a shift throughout the years from pediatric cases to adult cases, and now we're looking at older adults actually. And looking at the seroprevalence data, we can see that across the years, there has also been a decrease in seroprevalence, which may actually explain the shift of dengue cases to adults and then older adults. Now, the challenges of this is that dengue in older adults may present more atypically, making it even more challenging to diagnose. So this is actually a prospective study by Prof. Leo's group on a group of patients presenting acutely with fever in less than 72 hours to primary care. So you can see that the gray color actually signifies patients older than 56. And we can see that there are less classical symptoms such as less myalgia, less arthralgia, less retroorbital pain in older adults, making it difficult for the frontline clinicians to suspect dengue. And the other thing about dengue is as well is that we currently use the 2009 WHO guidelines warning signs to help us stratify patients. And what we usually use is what we call the warning signs. So they are the warning signs listed here, so of which there are 7. So abdominal pain or tenderness, persistent vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement more than 2 centimeters, and of course, increased hematocrit concurrent with rapid decrease in platelet count. Now, the unfortunate thing about the utility of warning signs is that although the sensitivity is really great, the specificity isn't that great. And we can see that it actually just ranges 48 to 52% for grades 2 to 4 DHF, as well as severe dengue. The other issue about warning signs is that majority actually occur on the same day or 1 day before development of severe disease. All this means that clinicians on the front line need to see patients very regularly. What is recommended is actually daily blood tests and daily clinical review, which can result in a great burden, especially in a dengue outbreak situation. So in summary, the diagnostic challenges are that the older adults are at risk, and at the same time, they are more likely to present atypically and have comorbidities that are risk factors for severe disease. And the warning signs that we are clinically using now are not optimal. Now, in terms of treatment, currently we only have supportive treatment from the whole course of the illness. So we can see for the first few days, there's viremia, and subsequently after entry into the critical phase where we clinicians are worried about, it's usually an immune host modulated response. Now, in the past, identification of specific therapeutics has been a major focus in recent decades. And there has been a fair number of therapeutic trials, especially repurposed drugs with antiviral activities such as chloroquine, sacalsavir, lovastatin, and they have all been explored in randomized clinical trials, but you can see that the outcomes are not really, there's no evidence to support their use in essence. And you can see that for antiviral usage, the inclusion criteria for all these trials are really tight within the first 48 hours to 72 hours. So it has its challenges. Use of antivirals has its challenges. It's a real world aspect. In terms of more recent data, there have been recent advancement in the development of other drugs for treatment of dengue. And these are some of the still ongoing trials. And these include antivirals to host-targeted drugs to reduce inflammation and or vascular pathologies such as ketotifen, metformin, Montelukast, and even zanamivir. And we're hopefully waiting for great outcomes for these. But of course, we're still waiting. Okay. And so in summary, I suppose this is a wish list per se. So we should hopefully in the future, we'll have antivirals to target the early viremia component. And then this will hopefully be able to be used in the prophylaxis stage as well. And then once a patient actually enters into the whole cytokine storm issues, there'll be available immune modulators as well as better supportive treatment. And of course, to be able to allow us to have the use of antivirals effectively, we will also need improved diagnostics as well as improved prognostication. And with that, I think I'm actually done.
Well, thank you, Poying. Indeed, as clinicians on the ground, there are a lot of challenges for many of us in the management of dengue. And I just want to bring back the WHO's target that we are looking at no dengue death by the year 2030. So I think there is still a lot of work that needs to be done to achieve the targets. Next, I'd like to call upon our third speaker, Professor Ani Winnie.
Okay. Okay, thank you, Prof. Leo. I think I just
So sorry, I am
Yeah.
muted.
Yes.
Thank you for reminding me. Yeah, so maybe I should just thank Poying first for giving us the updates in the clinical management. Indeed, it is something important for us. And thanks, Professor Ani. Thanks for reminding me that I'm still muted. And Professor Ani Unita Nilwan, she is the internal medicines and tropical infectious disease specialist based in Jakarta. She is the professor, lecturer, and researchers at the Chipo Hospital. That is the National Referral Center for Indonesia. She plays a pivotal roles in medical education as well as research. And she will bring to us her experience in the clinical and vector management of arboviruses in Indonesia. Professor Ani.
Thank you, Prof. Leo. I would like to first share my slides. Yes, first of all, thank you very much for inviting us to join to these meetings. And I would like to talk about the clinical and vector management of arbovirus in Indonesia, but maybe I would like to put it in a more wide spectrum. So our Ministry of Health for arbovirus focused on these four diseases, dengue, Zika, Japanese encephalitis, and Chikugunya. Even though, as you can see in the slides, that the proportion of cases reported in Indonesia is not is not similar for the number of cases for all diseases. And dengue is the most common, but for the vaccination, we have at the moment vaccination for dengue and Japanese encephalitis virus. So this is the surveillance mechanism that our government provide to the healthcare facilities. As you know that this is a very huge country with quite substantial number of healthcare facilities, not only in the big city, but also in a very remote area. So we have now the systematic program web-based that they can access for the suspected cases. They should fill in the form and then report it to the PHEOC, and then they have these guideline to send the samples and to manage and refer the case if it's necessary. And then the government, on the other hand, will then help them to check the sample for confirmed diagnosis. And we also have this, as you can see in this slide, the guideline or the strategic recommendation for the physician and also for the people on the field to know how to manage cases. And this is also then embedded in the routine discussion for all these healthcare facilities to improve their knowledge and also to do the monitoring to avoid the fail of making the diagnosis for the cases and also to reduce the mortality. And This is one of the facilities that provided by the government, the information system. But this is at the moment only apply for Zika and Japanese encephalitis virus. So it is not for all the available program for the arbovirus. Because for dengue, of course, we know that this is more established, and the government has another way to do the surveillance besides using these websites. So I would like to start with the not common ones, the Chikugunya in Indonesia. So as you can see here in 2023, the reported cases is not really that much. We at the moment only have the antibody-based diagnostic for Chikugunya, and then the case itself is only happen in the form of outbreak, so it is not sporadically reported in whole of the country. And for the other diseases like Japanese encephalitis, from 2014 to 2023, we found 145 cases. As you can see, it is also not found in all area of Indonesia, and it's diagnosis in children. And then we also already implement the immunization for the GE in West Borneo province and also in Bali, even though the case was not only reported by these two provinces. And now I would like to move to dengue infection. We do not really differentiate between the dengue virus and dengue hemorrhagic virus in the reporting system, so it's mixed together. And as you can see here that on the left side, this is in Bahasa, but I will explain it to you that the number of cases is actually decreased in 2022. From 142,000 to 50,000, and then also the mortality due to dengue is also decreased. And the map on the right side is showing the number of new cases for all over the country, and this map is also in a substantial number of changings between years, and this is the latest data. And for the dengue itself, since 1968, since the first cases was reported, as you can see here in the gray bar, there is the activities that we also conducted to do vector control from the larvicides, and then it's always adding and also improving. We provide also fogging and then do the mosquito nets, and then also this is one of the famous activities that we also introduce to the community to make sure that they have clean water, and then also to cover the garbages that not becoming the place for breeding for the mosquito, and also to make sure that all the activities, as you can see in the bottom, that can help to reduce the breeding site for the mosquito. Also the mosquito itself to reduce. And then at the moment, as you can see on the right side of the slides, that we already tried to implement the vector control by using the Wolbachia, but it is not for the whole country, but still as a pilot project. As you know that in Jakarta, since 2016, similar maybe to in Singapore, we already started the trial, and then now at the moment we have a tremendous reported decreasing number of cases and also the hospitalization. In this picture, you can see that the community received the eggs with the Wolbachia, and then we start to spread the mosquito with the Wolbachia, and then to this number of province as a pilot project that started this year. We hope to see the impact in the coming years. So hopefully this is similar successful with the trial in Yogyakarta and Bantul also expected. And then next, we are now having the vaccination for dengue virus. In 2016, the Indonesian government also already approved the first dengue vaccine, Denvaxia, but then unfortunately, we are not really having the real data on how the impact of the vaccination to the cases and whether the number of side effect of the vaccine, for example, the secondary infection is actually occur, but in 2017, then the vaccine is stopped to be used due to the other reports in the Philippines. But last year, the FDA of Indonesia already approved the vaccine for dengue, the new vaccine that already then introduced to the immunization program, not only for children, as you can see here, but also the implementation or the use of this dengue vaccine to adult. And this is the recommendation that been introduced from the Society of Internal Medicine. So I think for this vaccine, how it will be then implemented and how people is actually receive or want to use the vaccine because they are also being informed about the potential risk will only be known a bit later on because it's really just introduced to the community, I think early this year. So I think that all that I can share about the arboviruses in Indonesia. Thank you very much. I return the time to you. Thank you.
Well, thank you, Prof. Ani, for a very comprehensive overview of the arboviruses in Indonesia. Now I think we switch gear to Philippines. My pleasure to introduce to you Professor Ronjin Solante. He is the chairman of the Adult Infectious Disease and Tropical Medicines in the San Lazaro Hospital in the Philippines. And from 2011 to 2012, Professor Solante served as the president of Philippines Society for Microbiology and Infectious Diseases, in short, PSMID, which is an association of specialists that aim to curtail the spread of infectious disease in Philippines. And currently, he is the PSMID's chair of media and communications, which is one of the very important components, and standards of care subcommittees in tuberculosis. So you will hear from Professor Solante's the Philippines experience and also the sharings of Chikugunya. Please go ahead, Professor Solante.
Yeah, good morning. I hope you can hear me. Am I clear? So first of all, would like to thank the organizing committee for this invitation. And my focus will be really the part of the dengue here in the Philippines, an emerging threat, unraveling the complexities of dengue here in this part of the region, which is the Philippines. Okay, so Philippines is really a highly endemic country for this infection, not only dengue, but also with other arboviral infections like chikungunya. And these are the main reasons why in the Philippines, it's something like we deal dengue throughout the year. And if you look at the mortality rank in case fatality rate globally in the number of cases in Asia, we always are in the top 3 or the top 5, both in the number of dengue cases and also in the case fatality rate. Primarily driven by the fact that we have the 4 circulating serotype of dengue. We have the dengue 1, 2, 3, 4, and every year, some of the serotype may be dominant. And I think among most Asian countries, except for Indonesia and Thailand, we also have the serotype dengue 4. The transmission is year-round, but there are certain months in which the number of cases are really very high, like in the third and fourth quarter of the year. And this is something that we always observe in several years now regarding the increase in the cases, particularly after the COVID pandemic. And this is the trend in terms of how the dengue prevalence in the Philippines. You see here in the blue bar, this is the number of cases, and we have the highest number of cases in 2019, okay? And in 2023, last year, we also have one of the highest number of cases of dengue. And we know that in situations that when there is an increase in the number of cases, there is also a corresponding increase in the mortality. And if you look at how we deal with our experience in 2019, when the Philippines had a large-scale dengue outbreak, and the documented number of cases, these are just confirmed and cases reported from the different healthcare facilities from level 1, level 2 to level 3. So we have almost 500,000 cases, and our case fatality rate then was 0.39%. And we were only second to Sri Lanka during that year in terms of case fatality rate, and we were number 1 in Asia. If you look at the geographic challenge in the Philippines is that we are composed of 7,000 islands distributed into 17 regions, and that's really a tough one in terms of public health implementation of a highly infectious disease that is being transmitted by an transmitted through a mosquito. So you see here the distribution of the cases. It's more or less well distributed from the younger age group to the middle age group, including those who are in the adult group, particularly those who are 25 years and above. And this is just an indication that we don't have really a very good immunity against dengue because of the 4 serotypes that is circulating. And year-round, there are always this vulnerable population that can really catch this infection and develop the infection symptomatically, and some will really go to the hospital. So in this particular report in 2019, it was even published in the British Medical Journal with our case fatality rate being the highest in Asia during the time at 0.42%, way above in countries where also there is a very high rate of dengue, particularly Indonesia, Malaysia, or even Singapore. So what were the factors then that were enumerated most likely responsible for the increasing in the cases, okay? And of course, this is also the more or less the same reason why in some Asian countries, dengue is really a year-round problem, particularly the expansion of urbanization and increasing population size. And then this is also expected that there is also increase in the exposure of this vector, dengue vector with this mosquito. And at the same time, there is an effect on the climate change related ecological factors. Like in 2019, because of what we call the La Nina, there were longer rainy seasons and higher ambient temperatures. And that's why there was really a higher number of these mosquitoes, leading to intensified dengue transmission. But when you look at how some of these patients were also clinically managed, there's also part of some of the gaps that doctors or even the community level healthcare facility have some limitations. So there is lack of healthcare seeking behavior. This is on the part of the patients. Most of the time when they go to the hospital or when they go to the facility, they already have some signs of warning signs of dengue, moderate to severe. And that's the reason why that the fatality rate, the case fatality rate was also very high. And a year before this, the WHO sent a group of investigators in the Philippines just to look at why is there increase in the mortality. And they went into 3 regions, okay, and look at into tertiary hospitals, tertiary level management of dengue. And they found out three most common causes of the mortality. Number one, on the part of the patient, that the delay in presentation to the healthcare system, resulting in delayed admission, and hence delayed institution of appropriate rehydration. And this is the case why we have a higher case fatality rate among the younger population, especially those who are 9 years old and below. The second reason then is that there is also a delay in instituting appropriate rehydration measures in hospitalized patients, because that some of them are afraid that there will be also increase in the fluid overload. But ironically, some of these hospitals that reported increase in the mortality is also the fluid overload, because I think in some of this investigation, they found out that during the time that when the patient is already in the critical phase, when patient's platelet count is decreasing, but the patient is already afebrile, most of the doctors load the patient with a lot of fluids, and during the resorption period or the recovery period, fluids goes back to the third phase, and that's why a lot of this younger population died because of pulmonary congestion. So the WHO made some of these guidelines, and they want the clinical society, the Department of Health, to look into specific interventions that are related with higher mortality so that it can be prevented. One of these is early diagnosis and indication for admission. And we did a lot of this educational forum, not only in the Department of Health, but also with the help of the clinical societies like PSMID, teaching some of these clinicians when to detect, when to suspect dengue, and when to give an indication that they have to be seen in the hospital instead of the primary or the secondary level of care. And then it's important also to teach again the doctors the detection of plasma leakage and time-sensitive institution of fluid rehydration. Then we did also investigations and correction of common complications in cases where patients do not respond to conventional IV fluid therapy, like the infusion of plasma or protein or albumin. Then early detection of bleeding, and that's why I think it helped us a lot when we had this new WHO category or classifying patients with warning signs, in order for us to preempt the use of blood transfusion. And then at the same time, anticipate some unusual manifestations, particularly among our elderly population, wherein they don't usually manifest with the usual clinical manifestations of dengue. Some of them will have hypotension when they arrive in the emergency room, less of the fever, less of the myalgia, and some of them have a very unstable comorbidities leading to cardiac and pulmonary complications. And some of them also have co-infections with bacterial organism, and that's the reason why there's really a higher mortality when these elderly patients will have a severe dengue. And then the Department of Health has updated the clinical practice guidelines to give more emphasis, specific emphasis on the clinical management, so that this particular area of manual and guideline were distributed, quite unique from that of the handbook of the WHO guideline in 2012. The manual was really specific in the management of fluid, the anticipation of complications, including preemptive hydration before patient will develop more severe form of dengue. So this type of management also teaches the level 1 care facility when to refer their patients to a higher level in order for a higher level clinical management, especially close monitoring of the vital signs and other laboratories. Okay, so this is a whole of community approach. All healthcare individuals were being taught on how to really diagnose dengue, not only in the community, but all levels of hospitals, doctors, nurses, and all, including the lower level 1 healthcare volunteers. So during the time and until now, it's more on focusing on what the appropriateness of doing managing patients with dengue, because we know that these complications can be prevented as long as patients are diagnosed early and early management. And at the same time, we identified some of the important aspects of the laboratory capabilities and diagnostics, the availability of NS1 in the community. Even at level 1, the Department of Health has mandated the local government to have those tests available. And then case reporting and management has been enhanced, including community communication, education, in order not only on the part of the healthcare workers, but also on the household to reduce exposure. And at this point, I would like to share with you, last year, the Philippine Pediatric Society came up with their updated algorithm in the management of dengue, because this is where the increased higher mortality rate was seen among those in the less than 9 years old. So they have several of these situation or scenario, like dengue without warning signs, what to do if they will be sent home, or dengue without warning signs, but with comorbidities or social conditions that require them to be admitted, dengue with warning signs, severe dengue, and those with severe dengue with plasma leakage. So this is really a deliberately made algorithm, so that from level 1, level 2, and level 3, there will be standardized management of dengue depending on the clinical presentation and severity. Now, I would like to shift gear to another arboviral infection, which is chikungunya. And this is also another infection that the Philippines has quite experienced last year. If you look at this headline here in Asian News Network, chikungunya cases up 382% in 2023 in the Philippines. And I think this is driven by the post-pandemic improve in the surveillance, and that's why we have a higher number of cases that has been detected. But luckily, our cases of chikungunya for several years has not been that bad compared to dengue. But last year, we had around 3,000 cases with no mortality. Most of these cases recovered, were self-limited, although some of them have what we call long-term complications in terms of joint pain. So the Department of Health has, again, reminded us of this particular habit of cleaning, what we call, this is our way of vector control, the 4S in fighting dengue: search and destroy mosquito breeding sites, seek early consultation on the part of those who may have symptoms already of dengue, then secure self-protection measures, and then support fagging, spraying in hotspots areas or only in selected areas. Okay. So as a whole, in terms of how should we approach this, is really at this point in time quite tough for the Philippines, because we don't have any vaccine available for dengue. And our level of management is really focused on clinical management and vector control in terms of cleaning the environment and reminding people of the breeding places of this mosquito may be something that we need to always control in order to control also the community transmission. I think that's my last slide. Thank you very much for your kind attention.
Thank you, Professor Solante. I think indeed you put together many of the key components and also many of the ground challenges in terms of how dengue can be better managed, as well as community engagement to ensure that the early detections, early diagnosis can be taken place. Fluid management is always one of the very challenging things. I think still a lot of work that we need to work to make sure that we can achieve no dengue death soon in 2030. It is still a long way to go. Now we switch to another speaker. She is Professor Nasikan from Thailand. Professor Nasikan is from the Divisions of Infectious Diseases and Tropical Medicines in the Department of Medicine's Faculty of Medicines in Sriraj Hospital, Mahindo University. She is a renowned adult infectious disease specialist in the Siriraj Hospital, and she contributes significantly to the medical field through clinical practices, research, and also through her academic involvement. She's going to give us very interesting presentations in terms of the nightmare to many of the clinicians here, distinguishing the different types of arboviruses clinically. And she's going to give us her experience distinguishing dengue and Zika from the diagnostic and treatment challenges. Professor Nasikan, please go ahead.
Thank you, and good morning, everyone. Thank you for your kind introduction, and also organizing committee for having me here. Today, the topic I would like to share is the distinguishing dengue and Zika diagnostic and treatment challenge. And this is my disclosure. Firstly, I would like to share about the burden of arthropod diseases in Thailand. We had around 200,000 cases of arthropod disease last year, with the dengue fever is the most prevalent, accounting for 85%, followed by malaria about 10%, and scrub typhus for 4%. You can see that less than 1% of all cases are caused by Zika and Chikugunya fever. However, it's been noted that this number is likely to be underestimated because of the data acquired from the passive surveillance system. And this slide shows the burden of dengue last year. You can see that in the green bar, this is the number of the case last year. You can see that the number is higher than those in 2022 and in the preceding 3 years. We show in the pink and blue line. The median age of all cases was 17 years. And we have documented the 175 dengue deaths last year, given the case fatality rate of 0.1%. And if we separated the number of cases by age group, we found that the highest incident rate is in children at age 5 to 14. However, it seemed to be the incidence rate seemed to be lower when the patient get older. However, the case fatality rate is higher in adult older than 25 years. And for Zika virus, we have almost 800 cases last year. And last year we have Zika fever is higher than those in 2022 and in the previous 3 years. And the median age of Zika cases is higher than dengue, around 35. And we have collected the Zika fever in pregnant women in the past 8 years. We have a total of 277 cases of Zika fever in pregnant women, and with a congenital Zika virus syndrome, around 31 cases. And when we comparing between dengue and Zika, both diseases actually around 80% of patients are asymptomatic. But if the patient have symptoms, dengue is more severe. Patient typically presented with a high-grade fever, headache, myalgia, can cause vascular leakage, even bleeding and death, and also shock syndrome. But in contrast, Zika have mild symptoms. Most patients complaining with maculopapular rash, with or without non-prurient conjunctivitis. But the most concerning of Zika virus infection is in pregnancy, because it can cause the microcephaly and also neurological defect in the fetus. Let's see the sample of dengue case. This is a 50-year-old man with sudden onset of fever, myalgia and nausea for 2 days. He had a high-grade fever, temperature of 39 degrees Celsius, but after examination was normal. On admission, he had quite a bit low white count, with white cell count of 3,800. Hematocrit of 47%, and platelet was normal. And they also follow up the complete blood count, and the white count still low, but platelet still normal. because the AS1 antigen was negative, so the clinician who care of patient suspected that he might have other diseases such as scrub or marine typhus. So they sent the investigation immunofluorescent assay for scrub and marine typhus and gave the doxycycline on day 3 of illness. And after doxycycline, the fever subsided. But actually, this case is actually dengue because dengue PCR came back positive for serotype 3. So it means that fever actually subsided spontaneously, but not from medication. So lesson learned from this case is in S1 antigen is not that sensitive. Actually, sensitivity is only around 60 to 70%, but it have very high specificity. So if in S1 antigen positive, you can use to diagnose dengue, but if the test is negative, you cannot completely rule out the dengue. And second case is a 30-year-old pregnant woman with a gestational age of 20 weeks. She presented with fever, macropapillary rash, and arthralgia for 3 days. On examination, she had only low-grade fever. We found a conjunctivitis and macropapillary rash on extremities, trunk, and face. And CBC complete blood count was relatively normal. Because in S1 antigen is negative and dengue antigen were positive. But because she's pregnant, and as I mentioned earlier, that Zika virus infection in pregnancy is the most concerning. So the clinician who care for the patient, they send Zika virus RNA in the blood and urine, and it came back positive. So in the pregnant with confirmed or possible Zika virus infection, we recommend to perform a serial fetal ultrasound every 4 weeks to monitor fetal growth and also to detect possible Zika virus associated fetal anomalies. We also had a study conducted in 2017 to 2019. We collected the data on 52 cases of Zika virus. We have median age of patient around 40 years with female predominance. You can see that almost everyone of patient have rash, 96%, and conjunctivitis and fever, we found only 60 to 70%. And for the complete blood count, it's pretty normal. And we also collected the sample from acute and convalescent period. The acute sample was provided by 52 patients at median time of 2 days, and half of patient gave blood and urine for testing, and the rest of the patient gave only blood and urine or urine for testing. And we found that the patient who have RT-PCR positive from the blood always have RT-PCR positive from urine. And for the convalescent sample, around 30% of patients still have RT-PCR positive, and mainly from the urine. So we conclude that obtaining urine samples in either acute or convalescent period for RT-PCR testing had a higher diagnostic yield for Zika virus infection. So, my conclusion is dengue cases are shifting from adolescents to adults. And we also observe increased risk of the severity and death of dengue in adults with comorbidities. And misdiagnosis of Zika virus infection in the pregnancy may raise the risk of fetal complication. And also we have to know the limitation of diagnostic tests, because it can cause the miss or delay diagnosis. And this can lead to overuse of investigation and antibiotics. That's all we have. Thank you very much.
Yeah, thank you, Professor Nasikan. Well, indeed, dengue is getting more and more complex in a way that we are now seeing a lot more older individuals with a lot of comorbidities. And Zika is still lurking around in Southeast Asia and continue to threaten many of the younger populations, especially those planning to get to start families, as well as those female in the reproductive age or already got pregnant. So thank you. And now we will move to our last speaker, Professor Lisa Ng. She will present to us emerging technologies, which I think is very important to support the clinicians in diagnosis and also therapeutics again, arbovirus infections. So Lisa comes with over 25 years of experience. She has numerous seminal discoveries as a senior authors and contribute significantly during the COVID period, as well as many of the challenges from the arboviruses. And she is one of the very well-known international figures in the arbovirus research. Let's hear from Professor Lisa Ng on how to differentiate dengue from other viruses. Lisa, please.
Thanks, Isin. I want to thank the organizers for having me. So, what I will be trying to give is a general overview on the importance of multidisciplinary research for infectious diseases. So we know that it's all intertwined in many ways. So, of course, I come from the A-Star Infectious Diseases Labs, one of the newest research institute that was established during the pandemic. So this just puts here, the 4 key pillars that I think all of us in this room have been focusing on, different parts of surveillance and then detection, intervention and prevention. I think this morning's talk, all covers in different aspects. So the mandate for the ID labs is to join in the global fight against infectious diseases, and how can we make use of basic science and research and work closer together with our partners, both in public health and clinical and also industry, to strengthen the translation. So the 3 key disease pillars of the ID labs are vector-borne. I think this, as we know, it's extremely important, which is why all of us are here this morning talking about vector-borne diseases. And respiratory diseases, obviously, is another important aspect that will continue to be important for many years. I think we are still just coming out from the pandemic. I think we do not need to repeat all the challenges that we have faced. But I have to say that pandemic actually reopened up several opportunities for us to look at vector-borne diseases, which I will show later. So the various investigators at the ID labs have capabilities from asset discovery, such as antigen discovery, biomarker identification, the various in vitro screening platforms that would actually be very relevant to understand mechanisms of disease pathogenesis. And it is this where we continue to work with important clinical partners like Prof. Liu Yisin, and also our partners at the DXD Hub in the area of diagnostics. So focusing on diagnostics, I guess it's just not about PCR. And I think the earlier speaker, Professor Nasikan, also showed, the importance of strengthening serological assays as well. So what I'm going to share later is one particular story that actually was done together with Prof. Liu Yisin and some other members that then sort of took a backseat during the pandemic. But I think right now it's important that we actually come back to it with new perspectives after COVID-19. So, okay, I think we know our vectors, which Dr. Judith Wong has already shared earlier. And so again, I'm not going to go into details because there have been various speakers have already given the introduction. And I think this now shows that we are in the region where there's a mix of the common vectors. And as a result, it is something that we will always be confronted with. They will carry flaviviruses, alpha viruses, and sometimes even a co-infection. And of course, not to mention, we have the parasites that could come in as well from other mosquito vectors. But I would just say that this is an area that I think it's going to continue to be very important despite the improved vector control. So I think this is where it's a concerted effort among all of us to look at different parts of the ecosystem. So Professor Nasikan has also explained, the overlapping clinical features. So I'm not going to go into that. And you can see that it's because of this that also made diagnostics very tricky as well. So this does shows a little a bit of explanation why there's a high level of cross-reactivity, because you can see that they do not deviate that much, and especially the 4 dengue serotypes, and not to mention with Zika. So for the next 5 minutes, I'm just going to share a little bit of some of the lessons learned during the Zika situation in Singapore, specifically on the area of serological diagnostics. And this was the collaborative efforts of Prof. Chong Chia-Yin from the KKH Women and Children's Hospital, and of course Prof. Liu, and Raymond Lin, who was looking from the National Public Health Laboratory perspective. So clearly, what we learned then was the lineage was also very different, from what was reported in Brazil and South America at that time. So just very quickly, we could see from here, from the patients that were collated from the hospitals, the clinical hospitals here, actually the levels of IgM detection using the virion-based ELISA assays, you see they actually develop fairly high, right? And quite early on, you are able to catch them. And obviously, the levels of IgG also started to get decent, after 2 weeks. And then after 1 month, I think they were still fairly detectable. And of course, we followed these patients for a longer period of time. And we also conducted in vitro neutralization assays using this serum. And they were actually highly neutralizing, and also some elements of cross-reactivity. Now, I would just want to make a long story short here. The effort in this part, it was the development of a linear B-cell epitope-based ELISA systems that covers the respective dominant antigens, specifically, yes, labeled here from the PRN to the E and the NS1 antigens. And we actually had 2 different libraries, one specifically for Zika and another for dengue. And of course, we had also dengue patient samples that were collated from NCID. And so after many multiple rounds of step-by-step ELISA, we were able to actually identify specific Zika epitopes that only recognize Zika. And also, we were able to identify dengue-specific epitopes as well. And obviously, the reasons for cross-reactivity, you can see clearly, needless to say, the common flavivirus epitopes, there were many, and they were distributed all around the genome. So with this identification, we then went on to evaluate these epitopes from patients that were collected in other parts of Southeast Asia. So we actually have a long-standing collaboration with the MESOT site led by previously Francois Noston. And so he had archival samples of dengue bacteria and a lot of unknown samples. And you could see from here, actually the profile was quite different, and it's expected, right? So even though the peptides actually were sensitive and fairly specific, you could see from here that not all of the dengue epitopes that are identified from the Singapore cohort actually could be picked up from the Thai cohort. And that's very obvious because it was a different serotype. But I have to say that actually gave a lot of encouragement actually to this series of epitopes, and actually gives a lot of opportunities for us to further improve the technology. So for the next 1 to 2 minutes, I'm just going to finish off to explain how can we then further improve some of these ELISA-based epitopes. And I have to say a lot of it was because of COVID. I think because of COVID, we were forced to confront with a lot of asks and new needs and new expectations in terms of diagnostics. So I think we are past the PCRs, and that will continue to be important, but we are aware that host-based diagnostics is another form of, it's another aspect that it will continue to have more exciting development in the years to come. So you can see that it's actually a combination of the pathogen detection and also the host immune responses using plasma antibodies or sera, or even the detection of immune cells that will be important. So with the epitope-based ELISA, it will be interesting to see how some of these readout using the epitopes could actually be improved in a different type of assays, whether is it a high throughput or is it a microarray platform. And I have to say that, in terms of diagnostics and disease monitoring, no single assay is ever enough. I think we need a combination, not just about multiplexing, but you need to look at the antibody response, the neutralizing antibodies, and also the immune cells, such as the T and B cells in such cases. So with that, I would like to thank you for your attention, and I'm happy to take any questions.
Thank you, Lisa. Now we have heard from all the 6 speakers, and we can move into the panel discussions. Before that, I just want to thank all the speakers for your excellent presentations and also abilities to keep to the time that allow us to have enough of the time to do Q&A. I would like to do it this way, and perhaps I can start with Dr. Judith Wong. And then we can move to discuss about the diagnostic, and then we can look into how best we can further improve clinical management to achieve no dengue death. So let me turn to Dr. Judith Wong. There seems to be a lot of interest in Wolbachia, whether or not it actually disturbed the ecosystem, and also whether or not eventually there will be resistance to even the Wolbachia. There's one question. My questions to you is actually, you painted quite an optimistic picture towards how we can control the vectors and bring down the clinical cases. My questions to you is, how do you see climates coming into play? And also your predictions, how this will move ahead. Judith, let us hear from you.
Right. Thanks very much, Prof. Liu. Maybe on the first 2 questions first about the ecological impact of the Wolbachia releases, or the releases of Wolbachia carrying mosquitoes. Because eventually when we release the mosquitoes, these mosquitoes actually do not continue, because our technology that we use is the suppression technology. So they actually do not really persist in the environment. They do not continue to propagate. So we believe that on that note, there is minimal impact. And also the other consideration is that our releases are very much in the urban settings versus whether rural or like these settings which are more natural. So in terms of ecological niches, it would also be more minimal, because if you think about what's around in urban settings, they would be pests anyway. Yeah, so that's on the ecological impact. There was also a question about Wolbachia resistance. Again, because we use the suppression approach, we have not seen resistance to that. And also, instead, in terms of monitoring, we don't really monitor about the resistance to Wolbachia, but in general, what we monitor is actually the fitness of the Wolbachia carrying Aedes aegypti and its ability to cross with or to mate with wild type. So we do a flip in terms of monitoring to ensure that the technology is still efficacious. Now, with regards to Prof. Liu, your question about the picture of epidemiology and control, I think that we are really still all at risk, but I just wanted to share that rather than looking at it in a doom and gloom, we should try to advance some of these technologies which could give us hope. And with regards to climate, we do know that with climate change, the spread of vectors would increase. So that means places that may not have seen like Aedes aegypti or Aedes albopictus, they may now see like these vectors spreading further. Of course, in our region, we would have already seen that, and we know that Singapore has, and also some of the other countries already have Aedes aegypti and Aedes albopictus. So in terms of risk through our region, I think it's not really about the spread of vectors, but what it could mean is that as these vectors spread to other countries, we may need to monitor the virus evolution and the virus transmission. and in turn think about like introductions to our country, because it will spread further, and it means that there could be more intense virus transmission, and thereafter in turn then it would come back in terms of inflows to our region, and we need to continue to monitor whether or not, for example, there are more virus strains with higher epidemic potential and so on. Yeah, thank you.
Yeah, thanks, Judith. I'm actually thinking that, with the global warming, I think the warming is being felt everywhere, right, including us in the tropical area. So whether or not these elevations of the ground temperature in this part of the world, in Southeast Asia, in Singapore, in the tropics, whether or not it is advantageous effect, I don't know. But it's an interesting thought, right? Whether or not the high temperature could actually retard some of the activities of the mosquitoes. We don't know. But can I also ask Professor Ani, because I also noticed that in Indonesia, you are also using the Wolbachia technology. Would you like to share your experience?
Thank you, Professor Leo. Yes, actually, the Ministry of Health is just recently late last year introducing the pilot project for the Wolbachia itself. But the initial trial was conducted in Yogyakarta, and then so far there are positive effects on this way of vector control using Wolbachia in the reducing of mortality and also cases in that particular area for trial. But it is really still in a small scale. And then also at the moment, we are still also struggling with the acceptance of the community of introducing this new mechanism, because they are also have the worries about the changing of mosquito will be also have another impact due to this way of vector control. So that is why I think we are not really have a huge experience in terms of this mechanism of control for the country, but it's only in aspect for the trial, and the result is actually good for controlling the case. Thank you.
It's very impressive, because I think in your presentation, it did reduce significantly the dengue cases. Can I just ask whether you release both male and female Wolbachia mosquitoes?
Yes, in Indonesia, we use both. So it might be a little bit different with the one that been introducing in Singapore, because as I know that you are only involved the female mosquito, but in Indonesia, we are using both male and female mosquito with the Wolbachia technology. Yes.
Yeah, thank you. And I just want to echo what Judith had just mentioned. We just have to embrace new technology and constantly find new way to combat many of all these vector-borne diseases. Okay, so I also want to encourage our esteemed speakers here. If you do have any questions, just raise your hand. I think this is interactive sessions. And I will try to include all the questions that's being posted in the Q&A as much as we can along the way in our discussions. I'd like to move on to talking about the vaccine. So currently there are 2 commercially available vaccines or registered vaccine from Sanofi as well as Takeda. And Indonesia has both. And I think Thailand has both as well. Just want to hear the view from our speakers here. How do you think the dengue vaccines use case in your respective country? Perhaps I start from Professor Ani first.
Yes, thank you, Prof. Leo. So for the dengue vaccine itself, since I'm an adult physician for ID, so I have a discussion a lot with my pediatrician colleague. So for the first vaccine by Sanofi, our Professor Sri is actually one also the investigator in the trials, and then the implementation of this first Sanofi vaccine actually in Indonesia is not really resulted in a real data on how it will impact the increase of cases, the increase of cases due to the vaccination. Because I think since it's been receiving the FDA approval in 2016, and then not more than a year later, the vaccination is actually stopped because of an issue not in our country, but then there's like a the warning or reminder from the Sanofi itself to wait for the use of this vaccine. But for the new one, the one that released by Takeda, it is true that Indonesia might be one of the first country that given approval for the vaccination, and it will not be only implemented in children. We also, in adult physician, we also recommend to the use of this vaccination up to the age of 45 years of age. Even though that we realize now that with the longer age expectation, there are more older people getting the infection, that this might be the one that might have a more risk for having severe infection due to the comorbidity. But at the moment, our FDA only approved it in the age of 45 years of age. But still, we still need to see on how this will impact the potential occurrence of the ADE, even though the studies of the vaccine itself show no worrisome about the different serotype infection after the vaccination. I think that's what I can say for.
Yeah, thank you. Thank you for sharing this. As to why Indonesia decided to have the age cutoff at 45 years old. So certainly, we all worry about the potential adverse effect that we do not have clear certainty in terms of the adverse effect at this point in time. Indeed, for dengue in these regions, we are seeing that the demographic changes from younger populations to the older populations, but most of the dengue vaccines trial are basically still working on the younger children, and that gave a lot of difficulties in terms of how we interpret or immunobridging to the older individuals. So perhaps let me hear from Po Ying and also Professor Nasikan. We are all adult infectious disease clinicians, so I think this is something that I think is all in our mind.
Thank you, Professor Liu. In Thailand, dengue vaccine, from the Takeda, it was approved in May last year, and about about 60,000 doses have been distributed. And actually, it's kind of widely available, but not everyone can access to the vaccine. I'm not sure for other countries, but in Thailand, we have limited budget, so we have to, everyone have to pay vaccine by themselves. So it means some patient may not access to the vaccine. But as I mentioned earlier, dengue is quite severe in adults. So for me, I will recommend to patients who have like a comorbidities and also have some severe dengue in the past. And also we just launched the vaccine guideline for adults last year, in May last year, and we recommended for the dengue vaccine, we recommend from age 4 to 60 years because we use the immunobridging data. That's our share.
Yeah, and thank you. So you have both Sanofi and Takeda vaccines. Which one do you prefer, or which one that it will come into the national program?
In the national program, we for the guideline, we recommend we just give the data and what difference between both vaccine. For the first vaccine, maybe we recommend for just only the one who have history of dengue before and may serological positive. But for the second one, you can you can get the vaccine without any like a serological data. So we just give the guideline, and when we recommend a patient, we just explain the data. But I would say that the second one is more valuable and more acceptable for the patients, because they don't need any like a history or confirmed dengue before. So we can just if they have money, we can use it.
Thank you. So Pui, we have only one, right?
Yes,
That is
only
approved
Dengue,
by HSA. Dengue is not available in Singapore, not registered in Singapore. So in your opinions, would you recommend to just sit tight and watch and wait for the MSD or the NIH vaccines to come out? Or what is your view?
So I think because we only have Dengue and it's only for 12 to 45 years old, so and our force of infection isn't that high, and we are seeing more elderly dengue as well. So even for people who are keen for dengue vaccine, sometimes they don't meet the age requirement already. So for this group of patients, it's out of recommendations. Now for those who are within recommendations, it's very small proportion actually who are keen. And Dengue is also 3 doses, 0, 6, 12 months. So the commitment is also there required, and the price is also not extremely affordable, I would say. So I think even before our recommendations as a physician, their keenness in terms of the general population isn't that great. Some people are keen to have a dengue vaccine, but they have never had a previous dengue infection, so they're also not eligible. So I would say that for the current status in Singapore, is majority, I think, is sitting and waiting to see whether there is a better vaccine in the horizon that may be available in the near future. Now, for the people who are within the acceptable age group of 12 to 45, and they have had a previous dengue infection, and they really don't want, as in they weigh their own risk appetite, and they don't want to get a second more serious dengue infection, then yes, I do think that is a appropriate recommendation that they can go ahead to have the vaccine.
Thank you. I would like to move on to ask the questions to Professor Solanti. You presented something on chikungunya, and I think chikungunya is still something that is important. The disease is still something important in this part of the world, and is episodic on and off. So in other words, it's unlike dengue, is whole year round. Sometimes we have to anticipate that we may have a huge chikungunya wave. I hope not, but it could happen. In your opinions, how do you think about the new chikungunya vaccine? Would you think that you will have a use case in this part of the world?
Yeah, I think so. That's an important intervention. No? For me, as an infectious disease specialist, vaccine will always have an important role in the prevention, particularly in most countries like Asian countries, where we have all these arboviral infections. And the only problem now is really if these companies will be filing their CPR or marketing these vaccines in the Philippines, because the history of vaccines in the Philippines may not that be good, with the controversy of the dengue vaccine. And in fact, that's a very big challenge for us now, because the Dengue has filed now for a CPR here in the Philippines, but they're taking longer to evaluate it. So there might be some political insinuations there, and we really need that, no? Because right now, in fact, when we had that surge of dengue the last 2 to 3 quarters of last year, and there was also chikungunya, the increased awareness of the vaccine because of our experience with dengue, it was also been brought up in the government, and a lot of these people are really cold when we talk about dengue vaccine. But for the other vaccines, vaccine-related infections, it has also affected, no? Like the pneumococcal, the influenza, the uptake is still very low among adults. So it's quite a tough question whether if it's introduced here in the Philippines, because unlike dengue, where you have an increased mortality, then people will really have to have the vaccine. For pneumonia, there's also higher mortality. But when you say a vaccine that will prevent chikungunya, and most of the time, chikungunya will only have a self-limited course, and in some patients, like those who are in the adult population, the only most common complication is really the joint pain. So that's really tough thing to really promote.
Yeah, thank you. It's very interesting indeed, affecting mostly the older individuals. Again, the older age group seems to be, bearing the brunt of the arbovirus infections. So can I just ask our panels here, would you be now looking at chikungunya vaccines and keep it in the drawer and use it only for outbreak? In other words, it's outbreak vaccines in your mind, because, it's kind of episodic, right? Yeah. So will you approve would you give advice to your ministry or, to your own FDA to say that, okay, the data is there. We can approve it, but we're not going to use it, but we just keep it in the drawer, as and when the outbreak, then I may just take it out, without spending more time, going through the registration.
Yeah, the point now is that we want to focus on the private sector population, because looking at the government, I think it's really tough to give a recommendation, particularly with any of these vaccines, because when you recommend a vaccine, the government will spend, and it entails also budget. But the other market here in the Philippines is driven by the private sector, meaning the private doctors. Like in our society, the Philippine Society for Infectious Diseases, we are the drivers. We formulated vaccine recommendation and guideline, and that's where most of our recommendations and target populations are among the private sector. And I think that's our current position now, that if it is approved by the FDA, at least it should be approved for the private market.
Thank you. I think I'd like to move on to the diagnostic part. Certainly is a huge challenge, for arboviruses. It's a lot of serological cross reactions, and many of us rely on PCR. We just heard from Professor Lisa Ng that we want to move away from PCR. We want to have POCT, where the point of care test that is rapid, that we can use near patients, bedside. And obviously, serology is still up there. There's something that is important too, especially when we need to look at the seroprevalence to understand our own population, previous exposure, and also using that to calculate the risk in the future. So Professor Nasikan mentioned earlier on NS1 sensitivity. It's just barely around 60 to 70% in Thailand. And PCR is expensive. It is definitely not near patient. So let me just open this up to our panels here. How do you see, what would be the ideal, and what do you hope to see in terms of how we can improve the diagnostic capability?
Yeah, so if I may, given that in elderly dengue, we really have a lot of atypical presentations and it can be quite difficult. So as in clinicians, a wish list will be something that is non-invasive actually, if that is possible. Something that can tell me at least a serotype as well, because while we wait for a dengue vaccine that can actually target all 4 serotypes well. So I think knowing the serotype data is actually something that's valuable, while we don't have a vaccine that can target all 4 serotypes or is protective for all 4 serotypes to a great extent. And of course, given the challenges of flaviviral infections, given that it is sometimes very non-specific in terms of the signs and symptoms, something that can differentiate across all the possible flaviviruses, something that can tell me this is Chik, this is Zika, this is dengue, or a combination of whichever. So something like that will be excellent and a dream.
Yeah, so you'll be a challenge to Professor Lisa Ng, right? One drop of blood and it can tell you whether it could be, Zika or Chikugunya or or dengue, and also dengue serotypes. Now, coming back to dengue serotypes, there's some questions from the audience about the severity. Is it true that different serotypes give you different severity?
So yes, there has been, I think, many retrospective data that suggests that certain serotypes, and within the serotypes itself, certain genotypes that can predict severity. And then there are also some data that suggest that the sequential way of the serotype, so for people who have secondary dengue, if their first serotype was a 2 followed by a 1, now they get more serious outcomes. So there is some data to suggest this. But of course, we need to parse it out more carefully because some of these data are quite old, so we're not very certain whether this is universally true. So I think we're still waiting for more concrete data on that, but there's definitely a certain degree of worry there.
Yes, I think it's something important. And again, I want to throw it back to all our panelists over here. Sharing data is something that is important for us to learn from one another. So coming back to looking at different serotypes and also severity, certainly we need either PCR, we need the genomic studies. So do you think that within our regions, will this be one of the collaborative topics that we can talk about in terms of genomic surveillance, looking at serotypes and looking at whether or not there's any difference in clinical manifestations and also disease severity and outcome?
Go
sorry.
ahead.
Okay. Yes, I think direction now is really more on the diagnostic, and I highly appreciate the presentation of Professor Lisa because of the variability now that you have to modify your diagnostic test. And a lot of times when we have this more severe form of dengue, we really cannot just generalize that it's dengue, because as we know, there are specific serotype that is also related with dengue severity. And particularly in the elderly population, we're seeing a lot of these new cases now, and genotyping, serotyping will add another layer of knowledge for us to give us better information among our patients when they will be admitted in the hospital. And I think predicting the severity based on identifying severity or predicting severity based on genotype and serotype will help clinicians also manage these patients more robust and closely monitoring these patients. Thank you.
Well, sorry.
Yeah, maybe could I jump in here?
Yes, Judith, and followed by Professor Nasikan.
Okay, thanks, Prof. Yeo. Yeah, so I think I really agree with Prof. Solento's comment. In that, and I also think that we do want to also advocate more collaboration in like connecting the lab and the clinicians. So, for example, in NEA, we have been setting up a regional surveillance program called United Dengue, where we have been sharing the serotype information with countries who participate. And it is really like something that is like taking like a few countries are being involved, but I think definitely more of us can be more involved in this. And also with like learning from COVID, we really know now how to share genomic information, putting it on GSAID and so on. So we really can pivot all these knowledge really to dengue, and really understanding the different serotypes and how they are a link to severity would be very important. So the like surveillance data and how that in turn plays out in terms of dengue severity in the patient would be very important. So really, I think it would be an avenue where we can collaborate more, like both the lab and like clinicians, and then also cross borders. Thank you.
Thank you, Judith. Professor Nasikan?
Yes, in my opinion, as the adult infectious diseases, for me, it's quite challenging to actually differentiate between arbovirus and also some bacterial infection in like a first few days, especially in the older adults. So to me, I actually would like something that accurate. I mean, to exclude dengue first, and also for the bacterial infections, because actually for Zika and Chikugunya, it's kind of no mortality, but something that maybe have problem in the long run, like a Chikugunya, but Zika is just only in the pregnant women. So if we would like to use the like a diagnostic test more cost effectiveness, so for me, I would like to exclude dengue first, and then some bacterial, and then it's okay for Zika and Chikungunya, just only some in some like a population. Thank you.
Yeah, I totally agree with you. It's very, very practical approach. It's still a long way to go, I must say. NS1, even in our own hands in Singapore, is also somewhere around 70–80%, with not as that many secondary infections in our population. And any other suggestions and feedback from our panelists here? Because personally, I would like to call for the attentions of the multiple partners that make this webinar happen. And how can we then bring this to the further step in terms of reflecting on what we have learned today and what would be the useful collaborative efforts that we can continue to work on. I think we need some higher level understandings about the needs to do certain research and also regional collaborations. And of course, funding is something that is on the top of the mind of many people to get things done. Yes, Lisa, you have your hands up.
Yes, thanks, Yisin, and so to my fellow panel members. I just want to add a point, where I did not really indicate that PCR is not important. I think what I want to say is that PCR itself is not the only type of diagnostics. I think it will continue to have its purpose and importance. But I think the point that I want to raise here is perhaps, with our different panels here that you're representing your different organizations, maybe we do not need to do the same type of assays for every organization. I think it's more important which are the assays that it will be most relevant to you and what are the key immediate questions that you will benefit. So I think some of the serology-based assays definitely has a lot of potential, but also it will be challenging to move forward because of the current limitation of the technology at the moment. It's something that if you want something super sensitive and miniaturized, then it will come at a cost. I think this is not something that is relevant to everybody. I think if we want cheap, you said you want cheap and good. I think then that's also another part where then in terms of sensitivity, we may lose out. So I think then Yisin brought out a point where, if you're talking about the surveillance or genomic surveillance. So I was just thinking out loud, if, around the Southeast Asian region, if we are very clear on which are the current strains or isolates that are most dominant or predominant, and if we are able to share this piece of information very quickly, and then this is where researchers like myself, I'm sure there are many out there who can then update some of these immediate assays that would actually be very relevant to you or the region. I'm just thinking out loud. Of course, PCR is something that is already being done, but I think the serology base is something that we move very slowly. But if we were to look at the epitope base, these are peptides. It can be easily synthesized. If you're able to get a source, a company or a series of companies that are able to synthesize this very quickly, and they don't really need to be super great quality. It doesn't have to come from Europe or US, but actually something that I'm sure within your home countries, you all have this capacity to synthesize this amount. And this is where the sharing could come. And I think certain shared protocols and all that. And of course, the challenge is what is the readout. And I believe this is where the engineers will actually come in, those who make the sensors or the devices. I think if it's something that we want to do together, it's something that is built within the ASEAN countries, but then it's useful to us. It's something to think about. And is this something that, some ASEAN funds could aid this? And I don't think it's high cost, but it's something that, make use of what we already have, what we know, and we just try to build something small together. So just food for thought. Thanks, Izzy.
Yeah, thanks, Lisa. Absolutely. I think it's something important for thoughts that we have to bring back and reflect on, and as well as the same time provide the advocacy to have this happen, to have the ASEAN platform coming together with the involvement of epidemiologists, clinicians, laboratory, diagnostic developers together. I think perhaps to us is some of us is our dream that one day should come true, but it's not without the effort from many of us to advocate for this. Okay, so I know there's thumbs up for Q&A, but there's one last question that is being posted specifically to Professor Nasikan. How did you detect your Zika cases? Is it through surveillance or through clinical diagnosis?
It's actually through a clinical diagnosis, because the physician who care of that patient actually infectious diseases, and that is around that time is outbreak of Zika virus, and also she's pregnant. So it's serious to know that whether or not she have a Zika virus. So they decided to send further investigation for that case.
Thank you. So there again, it's very important for the clinicians, the epidemiologists, the laboratory people all come together to enhance clinical management, even through a good surveillance system as well. All right, so thumbs up for the Q&A. Let me pass this over to our host. And thank you all our esteemed panelists. It's indeed a very interactive and interesting discussion. Over to you.
Thank you, Prof. And our panelists for a very interesting, insightful, and really stimulating discussion for more collaboration in our region. Thank you. I learned so much about the challenges we face in our region for more effective and more, I guess, economical form of diagnostics. And I think this will spur us to actually do more research and development in this area. I sincerely hope that our region can find some avenues to collaborate. I take note of all the suggestions that came from Prof. Lisa and Prof. Leo. All right, so thank you very much. And with that, I think today's webinar will come to a close shortly. I just have one last favor to ask of our audience. We will be flashing a QR code as well as a link for a survey to the chat group. Please do give us your feedback on today's webinar, and ideas, no doubt, for collaborations, and then also what would you like to see in the future iterations. And with that, once again, I thank you very much for your time today, and I hope to see you again soon in the future webinars. The link will be left on the screen for a few minutes, so please do take time to fill up. Thank you.